Welcome everyone to our capstone event for our NAHDO Spotlight Series on Health Equity and Disparities. We have a few more people in the waiting room, and so we're going to just take another minute or so to get them all admitted. But while we are working on that, let me go ahead and give a recap of where we've been, what led us to this capstone. So we started back in May, on May 25th, which seemed just like yesterday, but it was forever ago actually, with a keynote address that was sponsored by Barry Dunn, and we had Dr. Gail Christopher talk to us about issues related to health equity, data, and disparities. On June 22nd, we had some breakout sessions on some of the key subtopics related to healthcare data, and that was sponsored by HSRI. And on July 27th, we had a data solution showcase where we were learning from various state data teams about what they're doing and how they're doing it in terms of health equity and disparities. And August 25th, we pivoted to look at how COVID has affected what it is that we know and what it is that we want to do and what we can do going forward regarding health equity and disparities. And today we are wrapping up our 5-part series, September 21st, with our capstone event. And this will be our last in the series. But I assure you that this topic is not going away. We will not have fully answered it by 4 p.m. Eastern today. And so anticipate that it will come up again in our annual conference. So if there's anybody that has not yet registered, please do so quickly. The early bird deadline for registering for the conference is September 25th. So today, on our agenda, we have 3 panelists: Meredith Roberts from Comagine Health, Dana Richardson from WHIO, and Karen Hampton from OHA in Oregon. Our moderator today was Stefan Gildemeister from the Minnesota Department of Health. And I'm going to go ahead and turn the time over to Stefan to lead us through our panel discussion.
Yeah, thank you, Norm. Can you all hear me? Can I get a thumbs up? I have a thumbs up. Excellent. Yeah, good morning, good afternoon, wherever you all are. Thank you for joining this discussion today, which of course follows an important and I think inspiring set of sessions that we've had with thought leaders, state representatives, and folks working in the consulting space. I'm just really pleased that I have the chance to moderate the capstone event and to be on a panel with such a fine group of panelists who I will introduce in a minute. But just a word on the plan. After the introductions, we'll take 7 or so minutes for each of the 3 panelists to give some opening remarks. And then we'll have a little bit of a discussion among the panelists before we open it up to everyone else in the audience. I think what we want to do is hear your questions via chat. And I think our friends from NAHDO or the APCD Council will alert me to them so that we're not missing any of your requests to engage. With that, welcome again, and thank you for having me here. Thank you to NAHDO and the Council for really bringing such a fantastic series together. On the panel today are Meredith Roberts, Dana Richardson, and Karen Hampton. Meredith is the Executive Director of Governance and Community Engagement for Comagine Health, a national nonprofit healthcare consulting company. Previously, she was a Senior Program Director working with total cost of care and payment reform programs and an Administrative Fellow and Manager of Clinical Planning at the Dana-Farber Cancer Institute in Boston. Earlier in her career, Ms. Roberts worked as a benefits manager for a large self-insured employer and as a consultant. She holds a bachelor's degree in psychology from Wesleyan University and a master's degree in health policy and management from the Harvard T.H. Chan School of Public Health. And Meredith, I think we agreed will go first, but I'll introduce Dana and Karen as well. Dana Richardson is the chief executive officer for the Wisconsin Health Information Organization. Do we say WHIO? Is that okay?
Yeah.
Nodding. Okay, good, good. And has been in this role for 6 years. Prior to joining WHIO, Ms. Richardson was director of the PCPI operations for the American Medical Association, where she staffed the PCPI board of directors and oversaw planning, operations, and member services for the program. Ms. Richardson led the development of the National Quality Registry Network, a learning system for organizations that support national clinical registries. Prior to her work with the AMA, Ms. Richardson was vice president of quality initiatives for the Wisconsin Hospital Association, where she developed Checkpoint, a voluntary public reporting program of hospital quality, and led several statewide collaborations to improve the quality of care provided by Wisconsin hospitals. Ms. Richardson began her career at a large integrated delivery system in Wisconsin, where she held positions within the health plan, medical center, and hospital. Ms. Richardson holds a Bachelor of Science degree in nursing and a Master's of Arts degree in business. Last, but certainly not least, is Karen Hampton, who is the program manager for the Oregon All-Payer Claims program, All-Payer All Claims program at the Oregon Health Authority. She has a law degree and a master's degree in public administration from the University of Oregon. Prior to joining APAC in 2017, Karen was with Oregon Vital Records for 17 years, including there as a business lead and then managing the web-based Vital Record system. She has also worked as a manager, research analyst, and a civil legal aid attorney. So we have a really set of rich experiences on the panel, and I'm really excited to be part of it. I may have not introduced myself. Again, Stefan Gildemeister, I direct the Health Economics program in the Minnesota Department of Health, where we focus on health service research and health policy analysis to inform policymaking in the state. As part of our role, we also administer the all-payer claims database in the state. So without further ado, Meredith, would you kick us off with some of your opening remarks or what you've gathered from the series?
I'm happy to. Thanks so much. So I want to thank NAHDO for inviting me to be a part of this panel today, which is comprised of old and new friends, which is always a pleasure. I'm really excited to see where this conversation goes. So I am not an analyst. One theme that struck with me from the Spotlight series was the importance of telling data-informed stories to effectively influence policy. You can't tell a story with data you don't have. And we all want to build a more equitable healthcare system. We realize that this will be a collective effort. To do so, data is a powerful tool that can help us get there and can challenge the story that is being told with existing data. As Dr. Christopher explained in her keynote, data allows us to provide policymakers with full pictures of inequities in health. Imagine how the story would shift if every community had the infrastructure they needed and data was captured at any point of care in a way that was structured and could be shared and reused by other service providers across programs. I'm also reflecting on Dr. Gonzalez's presentation about sexual orientation and gender identity, or SOGI, data collection. Although the volume of SOGI data, self-reported SOGI data being collected is increasing, there are still many barriers to get to that full picture, including lack of information and claims, as well as practices and policies that, for example, explicitly exclude gender-affirming care. That means that we can't possibly tell the stories of how this population encounters barriers and worse outcomes, or consider policies that could reduce these disparities. So while acknowledging these real limitations, what can we do to make sure that we, as health data organizations, remain responsible stewards of the data we have access to, while reporting meaningful analytics around health equity? I have 3 suggestions. 1, first, acknowledge who is over or underrepresented in performance measures. Most measures of cost, quality, and utilization rely on claims data, which usually excludes people who are uninsured or restrict denominators to people who saw a provider. This could underrepresent people with unreliable access to healthcare services. Adding balance measures like primary care utilization as a proxy helps to present a more complete picture of a population's health. Stratifying measures further illuminates inequities and provides clarity on where healthcare systems can better meet the unique needs of certain populations. Second, whenever possible, include complete and reliable race and ethnicity data. Good race data is necessary to identify racial inequities, but as we have heard over and over again, race identifiers are notoriously missing or inaccurate in healthcare data. Fortunately, enhanced data collection efforts like data linkage and data imputation methodologies are showing promising results in improving the completeness and reliability of race data. Third, when we can, we should combine multiple data sources to identify drivers of health inequities beyond patient characteristics and allow for multiple perspectives to be incorporated. This data can be collected directly from patients using things like social determinants of health screening tools and linked to other existing sources of data, including social service data and publicly available data sources. Those are just a few of my thoughts. I'm really looking forward to this discussion today. I learned an incredible amount during the series, and even though this topic is really hard, I was impressed by the quality and variety of the work being done around the country and all the thought leadership that was presented. So I think I'm handing it over to Dana now.
All right, well, thank you very much. And I too would like to thank NAHDO for sponsoring the Spotlight series. I think this is an emerging area, and it's, going to be very important for all of us to participate, to be thoughtful and diligent, and remain, keep this as a high priority within our organizations as it unfolds over the next several years. I was struck really by the amount of great work that was presented throughout the series. At the same time, it was a bit overwhelming to think about what is it we still don't know. There was a lot of holes, it seemed, that were still at the frontier of this work. One of the things that struck me is in part the lack of standards, and I guess because we all work with standardized data, we see the value of that. And I reflected back on to the presentation that was provided by ONC, where they indicated that they have created 900 essentially categories for race and ethnicity. And when I think about the practicality of 900 standards, I think to myself, that's not a standard. If everybody's going to be choosing out of that list of 900 what they want to include in their certified HIT system, then how do we ever get to a standard? So what is the right middle course, I guess, between what we have today, which is not enough, and what could become so complicated that it's hard to use and hard to make sense of? So I would encourage us all to be thinking about, how can we participate in that standardization process, and who really does that belong to? And I'm going to propose that it's really a federal activity. And the reason I say that is I think back to what happened in the APCD world. Each of us, as we brought up our regional or state APCDs, created our own data intake models. And, that's what there was. There was no national standardized intake model. And while I would, say today we have a good prototype, we don't have an agreement. We don't have, full support that says this is the way we will all collect data. And what that means is that for organizations like mine, what we do is close to, but not the same as, the de facto standard out there today. I think in the area of social determinants of health data, we have the opportunity, because we're on the forefront, to do it differently, right? We have the opportunity to say, no, we need this to happen soon, and we need the federal government to do that so that all of us can, work in that space and actually create data that's interoperable, not just data in another silo. And then I would also like to reflect on the SOGI presentations that were done in the last session. I give the presenters a lot of credit for the work that they have done. At the same time, I have a couple of very close friends and colleagues that work in this space in various efforts. And what I heard through those presentations were slightly different than what I have learned from them. And what that made me think as I reflected on it is that is such a moving landscape yet. And so what does that mean for all of us? In one of the presentations, they indicated that, non-gender, determination in general is about 77% of the population. In the millennials, it's 10%, but 25% of the Gen Z generation would respond that way. So that tells me that our cultural thinking around this is changing. And how do we maintain flexibility to allow those changes to be incorporated into the work that we do over time? At the same time, I would desperately like standards. I think it's going to be a balancing act we all need to participate in. So I am going to pass it over to Karen.
Thank you, Dana. I do think it's very interesting that we all are in similar positions, and yet there are, we're a Venn diagram. I want to add my thanks to NAHDO for doing the Spotlight series as well. I think some of the lessons I'm walking away with are slightly different. Some of my concerns and hopes are slightly different, but I think the one thing that we can agree on is there's a lot of work to be done, and we really want to move forward in a way that is useful for people in using the data and not just data for its own sake. So sort of the three things I walked away with from the series is what data do we have and need, how we should share that information once we have it, and then as a separate factor, is anyone listening? Because I think that came out in several of the presentations about, you're putting data out there, but is anyone really picking it up and using it? And what do you need to do to make it actually more usable for them, whether it's a matter of data analytics presentations and the usability from a layman perspective, or if it's a matter of social credibility. So I really very much enjoyed, as a call out for it, the mitigation planning on August 25th. Because I think that it highlighted one of the things that we face here in Oregon, and that's that populations can feel ignored and needs can be masked depending on the geographic you choose to report. If we're reporting statewide in Oregon, everything might look one way, yet 75% of our population lives up and down the I-5 corridor, and the others think that the people in either the coastal areas or Eastern Oregon may appropriately feel that their story is not being represented, even though their numbers are there. So what do we do to make sure that we're telling everyone's story? And the idea that it's likely that APCDs are not going to be able to tell the whole story. So one of the things that I want us to look for and talk about is how can we pair the data that is reasonably accessible for APCDs with information that fills in the gaps, that fills in information about who these people are, that fills in information about what never gets reported to an insurance company. So we in Oregon don't have it. So when we're telling you
Karen?
I think we've lost Karen's audio.
Karen, we lost your audio. Hang on a second. Karen, can you hear?
We cannot simply plant people in one place or another place for it. So So that's one of the things that I would love to hear us, talk more about without getting to 900 categories where people are flipping through 20 sheets to see which box they check. And hopefully they're at least doing it on the computer, but even that would be pretty overwhelming for me. But then, so we have the agreement that they're going to give the information, the agreement that once we receive information, it's going to be useful and used, and then agreement on how that data is going to be released and made available. I do think that there's a strong role for national processes, standards. However, I also want to point out that innovation does not happen at the national level. We have to have something for the state. In Oregon, one of the nice things is that our legislature does listen to APAC data. They've also told us exactly what we should and should not do. They've instructed us to follow the state's collection policies on race, ethnicity, language, disability, sexual orientation, and gender identity, which does not in any way match up with anything in the national forum and cannot be related to the census. So I think that I'm personally looking for that blend where things can roll up so that it's nationally usable and comparable, particularly in contiguous geographic areas, but also maintains the personality of the state and allows each state to be innovative in ways that might fail or might succeed and later be picked up by other states or even nationally. So this really was just a terrific series. And I look forward to discussing it with not only us three, but with everybody for the robustness that also demonstrates the holes, the need for more information, the need for more discussion, the need for us to find how we can work together to make it more useful for people in trying to resolve very important needs.
Thank you, Karen. We lost you there for a second, but I think we ended up hearing all the important things that you were sharing with us. So maybe to the audience, we had a conversation earlier this week to plan this panel, and we had such a good discussion, and I can't wait for us to take that planning discussion and move it into this public conversation. And I want to start out the following way. Many of you have spoken about the motivation for this work. And I think implicit in that was sort of a question about whose role is it to move us forward? And I think, Karen, you ended on the point sort of to say, yes, the federal government has a really important role, but also it's not the place where innovation happens. So maybe thinking about your respective perspectives, Meredith, Dana, and Karen, how do we balance the tension between needing national standards, but being unable to wait for them, needing to rely on financing for this work that typically comes from federal and state payers, but not finding innovation there, and yet wanting to move forward? Sort of as you think, a lot of our questions, I think, will be about, so what? What are the next steps? What's the roadmap? What are your thoughts on roles where the health plans in this, for example, as initiators and entities motivated to move us forward? If you could, would you reflect on that? Maybe starting in the order in which we started the presentation.
It's tricky, right? I mean, you can't get standardization and pockets of innovation at the same time. So you need to find the balance there. And maybe it's a situation where we agree on a standardized list of attributes, and then we allow for some portion of that to be more flexible in ways that will be meaningful to that individual region or state. I think there are ways we can think about this creatively. Personally, I'd be interested in cross-state efforts. So if we can get 3 or 4 states to agree that this is the question that they want to research, and they agree to the same methodology and ways to approach that research question, that could give us a really good sense of what is possible when you're looking at more than one state, but not waiting for the feds to, give us a guidebook on the best way to approach it.
Dana?
So I concur with some of what is Meredith has said, particularly that perhaps amongst us there could be a subset of states that could essentially come to agreement, and in my mind that would lead to a de facto standard, at least among those states, right? So that we have some ability to compare ourselves and share data on a larger geographic area. I do, though, still think that the federal government at some point is going to have to come forward with standards, because if we just work in our state silos, I don't think we're going to get there. And for me, the innovation isn't in the standards. Just like for me, the innovation isn't in the data. The innovation is in how you use it, how you use the information that comes out of those more standardized systems, how your particular geographic area could benefit from different applications of the information, different policies. So I think that there's still room for me in having standards, having standardized data, and at the same time be innovative at the community level. You had asked also about health plans and is there a role, and I'm not real confident that that's the right place to put that role, particularly because, when you think about what is really the work of a health plan, well, the work of the health plan is to manage risk, right? And to do so by being the insurer. They bring in the money and then they pay out money so that risk is spread across the entire pool. I don't necessarily see them as innovators in an area that is really a community-based issue. When we think about what underlies disparities, underlying disparities is poverty, right? And it's a community-based issue, as opposed to something that health plans have unique interest and expertise in. Karen?
Thank you, Dana. So again, I'm with the other two about we need to find where there's common ground, where we can move forward, that there needs to be some commonality among the states, or if you're speaking in isolation, you're speaking with a much smaller voice, and it's not as usable. I think one of the ways we can do that is to have some core items that have the national standard, and that if you vary from those, you make sure that you can plan to roll up to the national standard so you keep that information comparable. And that's one of the things that the Oregon Office of Equity and Inclusion has done in their, and I'm sorry, we always throw acronyms out, but their real D, race, ethnicity, and language, and disability is the D. And that they have many more than the CMS components for race and ethnicity, but they have already identified how those roll up into those categories. So if we're taking Oregon data and it's being used with other states, we're able to map and not have everybody have to figure out for themselves what it is. So I think that those are some of the things that we would need. Again, the state legislature in Oregon is very active, and they're going to tell us what to collect. So we would never be able to commit to a national standard without having a state supplemental file. But that doesn't mean that we can't do a lot of things. We can have the core items be truly core items. We can map our activities so that if we have a data requester that wants 4 states' data, our Department of Justice attorney has informed us that their interpretation of HIPAA is we cannot have a standard limited data set that goes out to everybody that qualifies for a limited data set. We have to review and build files for every single separate data request. That's following our attorney's opinion, and that's what we're going to do. That doesn't mean we can't have a shared application, a shared payment, and take responsibility for mapping our fields to the fields of the other states, so that when a data requester gets the data, either we can formulate it to fit the national standard or the group standard that we've agreed to, or at least, if they prefer, informed them of how they can use our data along with others, rather than just expecting each researcher to figure it out on their own. So I think there really is a lot that we can do. But one of the things that I think we really need to work on that we cannot get from the federal government is the concept of social license. The groups in Oregon that have been traditionally injured do not trust clean, quantitative data in any way. They will never value it until they truly feel involved at the point of collection and all the way up. That's probably going to mean, and one of the things that I would love to see for us, because I think our data has very strong value, is maybe as a national group or even as a regional group or within the state, which I think is probably where Oregon is going to start, looking at what qualitative data is out there that can be used with our quantitative data to fill some of the holes, to make people see like we're seeing them as a whole picture and we're not just seeing them as a number of services that they receive. When we hear from people that they wanted to have specific vaccine numbers for their particular group, and they were told they were statistically insignificant, it takes a lot of years to come back from being told you're statistically insignificant. And that's not only for race and ethnicity and language groups. In Oregon, it's also for geographic areas. Mm-hmm. If people don't trust your data, they're not going to use your data. So we have to build that trust by showing them that we're listening to them at the point of data collection creation all the way through the process. And that's I don't know how to do that. That's going to be a really hard climb. And I would love to have groups nationally that talk about how are we going to do that. So if we announce, the Oregon Health Authority has a goal of ending health inequities by 2030. My first thought is, who's going to say health inequities are done? Is it our data? Are we just going to say, congratulations, look, here's the data? Is it going to be each community group that says, yes, we can agree that we feel welcomed in every setting and we feel like they're listening to us? How are they going to tell us that? How are they going to know that? So there is absolutely need for our information in the pot, but I think it's more of, we're building a stew now instead of just having APCD data. So I do think that there's a lot of room for national coordination, interstate coordination for it. But I think we also need to look at, when I asked, is anyone listening? You know, are the legislators listening? Maybe. Are public health officials listening? Yes, because they're used to dealing with data. But are the people that have felt unrepresented in the past, are they listening to us to even hear that we're looking and trying to work with them? In Oregon, not necessarily, not yet. We're building that, and again, our Office of Equity and Inclusion, fortunately, is working with us on it. But that is a real drawback for our data really being used at this time. We have research credibility, we have data credibility, we don't have the social license credibility.
Yeah, thank you for that. I was going to take our conversation further down the path of roles and who helps with facilitating the discussion between states and federal government, but I'll come back to that. I want to pick up on what you said, Karen, what you concluded with right now in the space of social license and who is listening to the work that we do and what work do we need to do to have people most likely experiencing disparities and inequities understand what we're doing and trying to do and inform that process as well. And maybe the way I want to queue up this question, and I love you all, but the way I want to queue up the question is, as I think about NAHDO and the APCD Council, we're not a particularly diverse group of people. As panelists and as moderators, we're not particularly diverse, although of course we represent different experiences and life stages and all of that. What in your mind, how do we make progress on the question of representation of populations experiencing inequities and disparities in health and outcomes in analysis, state leadership, in consultant organizations, and in the federal government? What role does that play? How do we move us forward on the same question as we're asking in healthcare? If you never see a doctor who is like you, it's hard to really believe in the system. But I think the same is true in the health analytics and consultant space as well. How do we make progress? What's missing? Fix it for us, please. And anyone, no order, anyone jump on it, please.
Well, I'm happy to go first. Not that I have any solutions, maybe just an experience to share. So we are part of a statewide grant that is tasked with putting out disparities reports. And part of that grant is dedicated to using participatory design as a way to, try and garner more information from people that are in communities and community leaders. I will say, I believe it's a step in the right direction, first of all, but it's been more challenging than I think we expected it to be. And part of what I've learned is that we speak a very different language than lay people in communities do. And I find this to be a gap just in general, but it's particularly noticeable when you talk to people about what is important to them, right? And how do we learn to interpret what we receive, the information we receive back from them? So I think of it as, are we listening, right? How do we learn to listen and actually hear what's being said when the language we use is so different? And I've also somewhat noted that, for all good reasons, people are interested in what's important to them. And so it's hard to get a comprehensive view. So I think just by using this participatory design method, we're going to learn more. But it's not as easy as I think we expected it was going to be.
I'd say for me, I think it's really telling that during this entire Spotlight series, we didn't have a community-based organization presenting. And if we're serious about making sure that voices are at the table and helping design and helping explore stories that come out of analytics, they need to have a seat at the table. So I would be curious, in a future iteration of the Spotlight series, to really make sure that we're incorporating the voices of those people that we're reporting on and making sure that we give them room and space to tell us what they think, to tell us where we've missed the mark, to tell us what other questions that our analysis prompts for them. So that's something, I'm not going to say it's easy, nothing's easy in this space, but a relatively simple step that NAHDO could take if we are serious about participatory research, as Dana was explaining. One of the things that Karen said before that really rang true for me is that behind each piece of data, there is a true person. And if we are not understanding who that whole individual is, then we're missing a part of their story. We're making a lot of assumptions based on the data we have access to. And how do we incorporate meaningful qualitative data so that people's voices can be incorporated with those numbers that we see? I would love to explore that further as a group at NAHDO.
So, Stefan, I think you found an area where we all, have pretty broad agreement, and that agree with very much with what we need to do as far as doing outreach. Again, in Oregon, we'll probably rely heavily on our Office of Equity and Inclusion for bringing communities in, and that's for two reasons. One, they have the relationships with the communities. They have the staff that are experienced in that communication and bringing people together and finding out that our Office of Equity and Inclusion is within the Oregon Health Authority. So they have been talking with people about what are your health needs, what do you need from us, with the idea of, if we're going to try to really empower people, it's not us doing it, we're playing a supporting role. You know, we need to recognize that at some point, we're going to be the stage crew and other people are going to be on stage talking about what's going on. And our role is to make sure that they have everything they need when they need it. But the other reason that we're going to OEI is that we have to be careful about not asking people the same question 15 times.
Mm-hmm.
We need to really show them not only that we're listening, but that we're paying attention. And I make that distinction because each of the 15 programs that are asking are going to be listening. But we have to show that OHA is paying attention. We have to show that the state of Oregon is paying attention and not tasking this with the same thing and then having their data that they may consider very confidential stored in umpteen different places because we asked them that many times. The other thing that Dana was talking about that rang very true for me is the terminology and the difficulty in communicating effectively. And I think that also is something that we need to move away from the academic. Even today, if someone looks at, if people are interested in our data, it's like, oh, read our data user guide, which is written from a very academic, professional research point of view. It has a section on data limitations that gives you a chart on who is and is not included. That has nothing to do with the people, it's just percentages. It has nothing about, everyone knows that this procedure is not going to be covered by insurance. So nobody puts it through their insurance company, so we don't even know it exists. If you want to know about that, you need to go somewhere else. So I've really been stressing the idea that maybe we need to think of it more as data provenance. How many hands has it passed through? Where was it originally created and for what purpose? How many times has it been repurposed? You know, do we have a Frankenstein of data? In some ways we do a little bit, you know, but to really treat it as if this is something that people want to understand, but are not willing to invest 15 hours of research to even know what we're talking about. So as much as we can, Oregon's adopting clear language, most places are. It's really hard to have clear language and the precision we feel we need as researchers, that we don't feel we're misrepresenting the data by being too broad. You know, but if you get down to the little, this is the slice we're talking about right now, you've lost 98% of the audience because that's not what they're interested in, or they stopped listening when you started using technical jargon about the data limitations are. So I think that we really do need to rephrase the way we do it. The other thing we need to be careful of is using the same terminology for different things. We use the term primary care in Oregon for at least 7 different meanings. In that we have at least 7 different sets of CPT codes, healthcare providers that in one place or another in Oregon, we're calling primary care. So if we put something out to somebody, it's like, well, primary care shows, even if they're really knowledgeable, they have to raise their hand and say, which primary care are you talking about? So making that information more accessible as people need it, thinking about the difference between accessible and available, and I'm not even really sure which side each definition would fall on, but it's like we can tell people our data is accessible to them. If you have a server that can handle several billion rows of claims data in a secure firewall setting, our data is absolutely available to you. So we just really need to pay more attention and use the people in our various governments that have those connections, that have that knowledge that will allow us to listen and participate, but possibly other than our little section, possibly not lead.
Yeah, thank you, Karen. I think there's a lot for us to learn from how Oregon approaches community engagement and consumer engagement. And I personally would like to sort of systematically organize the lessons that we can take from you and from other states. I think a remaining question for me is, how do we diversify the data nerds, people who are in this group, people who are members to NAHDO. But I think, that's maybe a question that we can close with and discuss with NAHDO and the APCD Council, sort of what is the role of these organizations to bring the excitement about the work that we do to different communities, and how do we attract representatives of these communities into the work that we do. It's a huge hill to climb, but I think we have to start at some point. I wanted to pick up, and maybe we'll think of this as the last question that we're discussing here at that panel. I want to pick up on something that Dr. Christopher said in her opening statements. She said, we're pretty good with collecting data, and we've done it for 40 years, but we're not really good in documenting progress and creating accountability. And I wonder if all of you could reflect on those things really briefly, including as a guidance to this group or the leadership around NAHDO and the APCD Council. How can we collaborate to demonstrate progress, but also to create accountability? We're going to have another Capstone series of another series, spotlight series, probably on this in a couple of years again. I'm old enough to have been part of these discussions several times over my career. How do we manage not to repeat everything and sort of learn how to build the wheel anew and create agreement where we've had it 10, 15, 20 years ago? Karen, you look like you're ready.
That was misleading. I'm not particularly ready. I do want to say, though, that Oregon has absolutely and publicly scavenged ideas, processes from many other states. So we really appreciate the ability that NAHDO and other groups have given us to be able to do that. And I think that maybe is one of the things, is to try to build on what's occurring, to be able to think of it as modules. So, okay, so one state isn't just like us, but they've done this part that we think would work really well in Oregon, and have some sort of, one of the things I think that we're missing very much at OHA and the state government generally is librarianship. To really have some way of having that information where you can find the pieces that are working well and say, this worked really well there. Whatever is relevant. This is their demographic profile. This is their provider profile. This is how many hospital systems they have. Whatever you're looking at doing, to look for the similarities and what's worked, or at least move the needle forward in other areas, and then build from that in a way that doesn't necessarily mean each of us has to start and survey. Well, we wish it was 50 states, but survey a great number of states about what they're doing. So again, that's one of the areas where I think at least a national, if not a federal solution would really be fantastic, and helping us not inadvertently reinvent the wheel and make the same mistakes by having more easily awareness of what's going on in other states. And if we could do that not only on data collection and processing, but also from the community perspective, that would really be fantastic. And I think that the more publicity we can get, the more people will see that we are listening, and that we really need them to know that we are doing our best to actively hear what they're saying.
I completely agree, Karen. And, I feel like we're a small enough group that, looking at the names on the screen, there are plenty of people here today that I would feel comfortable calling tomorrow and asking them a directed question about what work they're doing. So the more of a sense of community we can build, and the more personal connections that we can foster, I think we have less of a risk in repeating others' mistakes. The other thing I'll just note that's a little bit off that topic is, what's changed between now and the last time we had this conversation? So I would argue two things are top of mind. One, we had a pandemic, and all of these kind of things that we were aware of kind of under the surface came very much to the surface and became a part of public discourse for the first time, that there are true inequities in how people receive care and their outcomes. We saw that all throughout the pandemic. We do not have to make that mistake again. Number two, we now have more robust community information exchanges. And I am really interested in understanding how those community information exchanges can help us do our jobs better. Because right now, the community information exchanges are making referrals to community-based organizations that when there isn't an identified inequity, those community-based organizations don't necessarily have the infrastructure or the robustness or the capacity to do anything with those referrals. So I think it would be really interesting to kind of think about how to put the data we all have together with what's coming out of a community information exchange and help fill some of those gaps that we're seeing when the CBOs are trying to reach those who are experiencing inequities.
So I guess I would just add that Wisconsin is not nearly as far along culturally as Oregon is. We don't have consensus across our state that this is important. And yes, I think a lot of people now recognize out of COVID that there are these inequities. I don't necessarily think, at least in Wisconsin, that everybody understands, well, why is it important to me to correct this, right? We haven't made that connection equally across our state. So we don't, for example, we don't have a community information exchange in this state. So we have farther to go. So good that you guys are out in front of me. I'll be calling you in 5 years when we get to that point, maybe. But it is a little bit more challenging in some states than others. And I would say, you know, there are likely states unrepresented or even represented within the group here today, the larger group, that aren't even as far along as we are. So, you know, we're all living in a different set of both opportunities and constraints. And I think we have to recognize that. I'm hopeful that, you know, as we move forward, that, you know, post-COVID, things don't go back to business as usual. I think we run the risk for that. Because memories can be long for certain things, but short for others.
Yep.
And so I think now is the time, really, to continue and elevate this conversation in every conversation that we have, because eventually it'll fade away until the next pandemic comes, monkeypox, right?
Yeah.
So we'll see.
Yeah, Dana, don't waste a crisis to transform systems. I have a couple of takeaways, and I see Karen, you were your hand is up. We don't have questions. A couple of comments, which I'll maybe integrate in what I've heard. Thinking about NAHDO and the APCD Council, but also us as a community, there's work to do, and there's much work to do. I think we want to look for conversations with community groups and maybe the kind of offices, Karen, that you spoke of, that many states have in the infrastructure, the Office of Equity, Disparities, etc. So maybe an idea for another series of discussion. We need linkages to the feds to tell them where we need them and where they're falling behind and where their conceptual thinking maybe misses the mark in terms of pragmatic approaches to progress and to create accountability. I think we need to come together to fill the innovation space. I think, Dana, you said that, how standards is not innovation, but how you use the data effectively. So I'd like for us to talk about this more and have NAHDO and the council assist us in that process. I think we need to talk about documenting progress, and creating accountability. Where do we want to be? And how do we get there? What is our role as NAHDO? And then the issue of attracting diversity, both to our work and to the audiences. There are lots of ideas that we could discuss. Sponsorships to our conferences, discussion groups, identifying students to present their experiences to us, and not just maybe in the APCD data space, but also in the qualitative data space. So those are a couple of my takeaways. Still don't see a question, though. I see a warning from Norm to say we need to be done by 3:55. I'm going to totally ignore that. And Karen, see if you wanted to close maybe with a comment or a question.
Well, it is a comment, and I just want to acknowledge that, you know, we used to think of being on a continuum, and we were trying to move to one side or the other wherever we were, and, you know, whichever we thought we wanted to go for. But I have since, you know, realized, and it's again, it's one of the things that is frequently shared in Oregon, is that really what we're doing is we're trying to build a wheel. So we're trying to build multiple spokes out in different directions, all at the same time, to have them be in the same place so that you're not limping along. You're able to roll forward equally. But I long for the simple days when I thought I only had to worry about a continuum. But now that I know that there are 15 or 20 different aspects that we want to reach out for and work on, it's even more of a need for national discussions and for standards to even know what we're trying to do and be able to speak to people effectively. But it is a really complex situation, and we might have 7 of the spokes ahead of another state. They might have 8 different spokes ahead of us, because it's not a single continuum that we have to deal with.
Yeah, those are great last words. I know I have, you know, maybe a half a dozen of additional questions that I wish I could discuss with you. We'll have to find another way of meeting up and talking about them. But just want to close by thanking the panel for a really fantastic discussion. Just so engaged and such good ideas coming from your respective perspectives. Again, thank you to NAHDO, the APCD Council, for convening the series, populating it with really smart participants, and then bringing us together to create not closure, but maybe a milestone from which then, as a Norm, as you said, from which we then move to the next step in the journey, or build the next spoke in the wheel. Thank you, everyone. Norm, if you want to close this meeting,
Yes.
Back to you.
Yeah, I did want to thank Stefan for volunteering to help us with this. It's been a fabulous discussion today, and a very fitting capstone to our discussion, which I agree. We did not end this conversation. We ended the series, but the conversation will very much continue, not only in our conference, but for sure in other many webinars and discussions to happen in the future. So thank you, everyone, and we'll see you in a few weeks at our next event.